our collaborative that's called OEZ. So that's our logo in the corner there. And it stands for the Ontario HIV Epidemiology and Surveillance Initiative. It's an initiative between the AIDS Bureau at the Ministry of Health and Long-Term Care, Public Health Ontario, especially at the Public Health Ontario Lab, the Public Health Agency of Canada, and the OHTN. So let me talk to you a little bit about where we get data to inform policy and programs in Ontario. Today, I'm going to talk to you primarily about laboratory data. That's the data that comes into Public Health Ontario labs. There's a big opportunity here in Ontario because all diagnostic and viral load testing essentially is done at those labs. So it's by almost by a privilege that all that data is housed in one place, which means that I'm not going to talk about it today, but it also means that we have both testing data, including negative tests, which is unique in a lot of jurisdictions, and is actually very helpful for looking at things like biomedical interventions, because over time we'll be able to understand more about who's testing and who's using PrEP, using these forms through the HIV testing programs. We have public health surveillance data, which is often based on laboratory data, but enhanced by the public health units, clinic and pharmacy data, administrative health services, cross-sectional surveys, cohort studies, and I'm sure many of the people here are going to be talking about some of these other data sources. But lab data here in Ontario is our best way to understand what's going on at a population level. So what's a new HIV diagnosis in Ontario? Well, historically here, it's been defined as almost new to Ontario. It doesn't mean that it's a new infection or even a new diagnosis. It could be someone who was infected in a different province or a different country and then moves to Ontario, receives a diagnostic test, and then is considered a new diagnosis. We also have anonymous testing here. So if people are testing both anonymously and nominally using their names, then we can end up with duplication. So it's actually very challenging just to understand the relationship between new diagnoses and new infections. So not only is it hard to parse between the new diagnoses who are actually newly diagnosed individuals, but new diagnoses aren't the same as newly infected. And understanding the effectiveness of some of the interventions we're talking about at the population level is going to take more time, because we know that from infection to diagnosis can take quite a bit of time. On average, I think it's probably around 4 years in many populations. But for some populations, that's even longer. So especially among women, we see longer times from infection to diagnosis. So here's a snapshot of what new diagnoses look like in Ontario. This is subject to all the biases that I just described, so you have to keep that in mind. But what you can see here is that from about 2008 to 2012, we were seeing a decrease in our numbers that somewhat stabilized and maybe has even increased since 2013. So at a minimum, we can say that we aren't seeing improvements in our new diagnoses. How this relates to new infections, I think, is more complex and needs to be analyzed in more detail. I'm going to talk to you a little bit about what we see when we break down these diagnoses by different factors. So when we look by sex, we see that there's some stability over time, with about 20% of our new diagnoses occurring among women. And both that count, that percentage has been somewhat stable, but that count has also increased between 2015 and 2016. So these are some areas where we really need to start thinking and drawing our attention, but we've also seen that the count has increased among men as well, but the percentage is higher among women. So many of you have seen this slide before, and I think it's something that's well known in the sector, where we look at new diagnoses by age and sex. So the light blue bars are looking at males only, and the dark blue bars are looking at females only. We see that it has a different looking distribution. So for females, that distribution looks kind of like a bell curve, with the peak is in middle age between 30 and 39. Whereas for males, you see two peaks. You see a peak at 25 to 29 and another peak later at 50 to 59. So what that tells us is there's probably different things going on in the male population compared to the female population in terms of transmission. And there's different populations that are going to require different interventions based on their needs and their place in life. So the HIV strategy in Ontario is based on priority populations. Often when we talk about HIV, we talk about exposures, but we're trying to shift that lens to thinking more about populations that are in need rather than just the behaviors that put people at risk. So when we take those priority populations across the bottom, it's hard not to use acronyms, but GBMSM, gay, bi, and men who have sex with men, African, Caribbean, Blacks, people who inject drugs, then Indigenous and at-risk women. So these are not mutually exclusive categories. So if a gay man who is ACB was diagnosed, then that person would be in both of those categories. So that's important to note. So what we see here is that you can note, in particular, from 2011 to 2016, that there's been an increase in people who inject drugs. And I don't think that this is surprising given what we know about what's going on in the opioid epidemic. But we have a stability among gay men and among African Caribbean Blacks. When we look at it by regions, so here across the bottom we have regions in Ontario, you can see that the highest counts are in Toronto both in 2015 and 2016. This isn't surprising given the fact that most people in Ontario live in Toronto. But it's always important to consider what the rates are, right? So when someone shows something like this just looking at counts, it's hard to distinguish because how does that relate to the population that lives in those different places? So here I'm showing you rates. So what this tells us is not only are there more people, the rate is actually higher in Toronto. So we know that there's particular concern here. But when we look at rates, we also see other areas come up as more important. So Ottawa, for instance, not only does Ottawa have the second highest rate in 2016, it's also seen a more dramatic increase. We also see, once you start looking at small numbers, like in Eastern Ontario, those numbers get smaller, but we're also seeing more increases there as well. So I think the point of surveillance data is really to start to give us ideas about where are the places we should be looking at and focusing on improving access and programs. We also see an increase in Southwest and Central West as well. So I can talk a lot about why we should not compare data across jurisdictions. So even in Canada, every province does things slightly differently. All definitions are slightly different. So our definition of new diagnoses in Ontario, where it includes people who are diagnosed elsewhere, obviously has some problems with it. That may not be true in other places. Epidemics are different in different places. So it's hard to compare across to say what's going on in one place compared to another. So after saying that, now I'm going to show you a chart comparing jurisdictions. So what you can see here, we just have broken down Toronto and Ontario, then comparing it to San Francisco, London, and New South Wales. So there has been clearly a dramatic decrease in San Francisco, a decrease in London, and especially given there's a few less data here for Toronto, we don't see that same dramatic decrease. But when we look at Ontario overall, the rate has been very stable since 2006 and is more similar to those larger jurisdictions. So when we're thinking about what's going on in places like San Francisco or London compared to Ontario, Ontario is a very diverse population. It's both urban, suburban, and rural. So we want to be comparing similar places. And we can also think about whether, in addition, are there similar epidemics? So it's challenging in Canada because we have such diverse provinces where not only data collection is different, but also the epidemic is quite different in different provinces and driven by different factors. I'm going to speed through this a little bit because I don't know, I feel like I'm running out of time. Am I 2 minutes? So we have this advantage in our data where we've been able to combine our diagnosis data and our viral load data to be able to look at what's actually happening with people over time. And this is new, and it was a great effort that was made prior to me coming to Ontario. So I get to show you the great results without having to do all the work. So when you look here, we see the number of people with diagnosed HIV living in Ontario, and this is, of course, an estimate. It's based on laboratory data. So if people were diagnosed and then never came back again, then they end up falling out of this data. So it's probably an underestimate of who's living with diagnosed HIV in Ontario, but we believe it's probably between 16,000 and 17,000 people. What's going on with those people when we look at the cascade is that we've seen pretty dramatic increases in cascade metrics over time. So since 2000, we were pretty good at getting people into care. So that dark blue graph, you can see that it's been fairly stable. It was just over 80% in 2000, and now it's over 87%. We've done much better about getting people on ART, and of course this is a lot to do with changes in guidelines. So we can see that has increased from, 55% in 2000 to over 80% in 2015. And along with that, as expected, we've seen an increase in the percentage of people who are virally suppressed, where it was only 40% in 2000, it's almost 80% in 2015. This shows that we've had quite a bit of increase, but when you think about prevention as treatment as prevention, there's still a population of people in Ontario who know they have HIV but are not necessarily virally suppressed. So that's something that's very important to consider when we think about interventions. Another piece here is when we look at the time from diagnosis to viral load suppression. So this, I think, is a really important indicator because it indicates a lot of things: access to treatment, access to care, and also how quickly people are able to get through the healthcare system. So in 2000, only 20% of people were virally suppressed within 6 months. That's increased to 40% in 2013. And if you look at people who were virally suppressed within a year, then it's over 60% of people were virally suppressed within a year. But the question is, can't we do better than that? It's time for us to start developing stricter metrics so that we can try to adhere. Can we get people virally suppressed in 3 months, for instance, or try to get a greater percentage of people virally suppressed within a year? That concludes the information that I have to present to you today. I want to thank first the organizers for inviting me to come talk to you today. I'd be remiss if I didn't thank the partners, especially the partners who hold the data, which is Public Health Ontario, and all the insights provided by the AIDS Bureau and the Public Health Agency of Canada. I thank the technical working group, some of who are represented here today, for all of their work. We have a steering committee that helps guide our work, and we have a champions committee made up of people in the community and at ASOs who help us interpret and understand what our findings mean for the community.
So can I put the microphone in front of somebody for a question?
Thank you, Abigail, for that presentation. My name is John McCullough. I'm a community member living with HIV. And you rightly said that there is a difference between somebody who's newly diagnosed and the incidence of new infections. And it seems to me that if we're to really get to zero and reduce the numbers, we need to dramatically shorten the gap between new infections and viral suppression. So I'm aware that the challenges of knowing how many people in Ontario are living with HIV but are not diagnosed, that is a real challenge, I know. Do you have any sense of what kind of numbers we might be looking at?
I'm smiling because I am working very closely with colleagues here at the table, Sharmista, who's going to talk at the end. We're trying to develop a model right now to better understand what that is. So hopefully by this time next year, Sharmista will be able to come back and tell you a great estimate for those numbers. Clearly, the approach that's been taken in the past is problematic for modeling because we need to really know who are people whose infection occurred in the province. So right now we're working on cleaning up our data so that Sharmista can actually do the modeling so that we can figure that out. But based on estimates from the Public Health Agency of Canada that have been done in the past, we think it's probably somewhere around 20% of people may be infected but not diagnosed in Ontario.
Thanks for that answer, Abigail. I'll look forward to the numbers when they arrive.
Rupert has a question or a comment or an answer. All three.
Mine was purely a question, actually. I'm wondering, obviously there's a lot of, I'm trying to think of my own practice. There's a lot of stigma out in the world about gay men and bisexual men. There's a lot of stigma out there about people living with HIV. And one of the nice things about Canada is that we have a relatively open policy. So I think, a number of the new patients that I get in clinic are gay men who have come to Canada from Nigeria. There was a lot of in the press that many people in the audience will know more about me in terms of opening the doors to people coming from Chechens, gay Chechens, many of whom would be living with HIV, coming to Ontario. What proportion, do we have a feeling for what proportion of these new numbers are people who are coming into Ontario from outside? And that would be a very positive thing that we see numbers increasing in that perspective versus transmission within the community, which would be a negative thing.
I think right now, and we're still working on this, but I think our best estimate is around 10%. Yeah.
10% is coming in from, okay.
Yeah. And so that would only include, when it was recorded. So the challenge always with this type of data is that it's what is written on the requisition forms or on the follow-up forms that physicians fill out. So the physician may know, but they don't put it on the form, then that's not included in the surveillance data. So we believe from how the forms are filled out that it's around 10%. But if a physician doesn't feel the need to write that down or doesn't fill out that form or doesn't see the significance, then that data is lost. So I always take a moment, if there are any physicians in the room, to encourage them to fill out forms as much as possible. Because I know how much they love filling out forms. They don't do any of that.
Are there other questions? We're going to have, again, a more deliberate Q&A at the end, but any more right now? And I think that was a great introduction, not only because of the, real beauty of your presentation itself, but again, it sort of set up some of the themes that I think we're going to be exploring. And I apologize for redacting some of it, but it helps to illustrate that, as you were saying, the reason picking apart the numbers is interesting. It really helps direct about, so what is possible, or what should we pursue here to work as those other cities have figured out in some way what works for them. Now, again, I'm from San Francisco. I could tell you, they still don't know why they have a lot of reductions. We hear a lot of things, well, more guys take PrEP, or, everybody takes a taxi cab to the clinic the day, and that seems to work, but we don't know exactly the cause and effect of all those things. But what we do know is that each location has really thought about their matter exquisitely and with more precision than we've been yet able to do, not that we're unwilling to do here, and that's what the rest of tonight is going to explore. And the reason Rupert asked a question is so we would segue nicely into his presentation, because he's next, and he's going to give us an overview of, what are the tools sort of before us and as they're being developed as a sort of introduction to the others.
Let me just plug our mailing list again. So you saw our website. I just took it off, of course. But if you go to www.oez.ca, you can join our mailing list and you will get updates as they are available. And there's going to be a report on Monday. So I really suggest you go home tonight and sign up so that you can get that hot off the press on Monday.
And my name's Rupert. I'm an HIV physician and also a researcher at University of Toronto, and most of my research is around HIV transmission. So I'm just going to be giving an overview, and everything that I talk about is going to be given to you in more detail by people who are more expert in the panel here. But it's just broad detail of the biomedical tools that are available for preventing HIV. And I think it's important to remember, again, in the context, Robert already said, these are the tools that are there, and how we actually roll these tools out, whether people take up these tools, whether people prescribe the tools, what are the barriers to using these tools, are all very important things to look at as well. Some of that is social sciences research, some of that is implementation research, and just having the tools is never enough to end an epidemic, but I think we do have some very good tools, and I'm just going to be talking about those biological tools today as the purpose for me, just to give a slide or two on things that are out there. So as I say, there are quite a few very effective biomedical approaches now, way more than we had a decade or so ago. Some might or might not be coming down the pipeline, and I'll again give a little bit of background to that. And my job is just to set the scene here. So I always like starting off with something that says, in the absence of any treatment, in the absence perhaps of not even knowing whether I'm living with HIV or not, what is the transmission risk in terms of sexual contact. And really, I just put this up because it's important to remember that most HIV exposures don't result in transmission, no matter what we're talking about. I think that the different places that we can get exposed to HIV when we're talking about sexual transmission is what dictates whether transmission happens or not. So for instance, I won't show you all the pictures, but the rectal mucosa is more susceptible to HIV than the vaginal mucosa and the penile mucosa, and those are more susceptible to HIV than the oral mucosa is. And so receptive anal sex, bottoming, whether you're male or female, penile vaginal sex and oral sex have quite different rates of transmission, and roughly speaking, they're about tenfold different. So one's about 50 to 100 exposures results in one transmission for exposure in the rectum. If we're talking penile vaginal sex, it's more like 1 in 500 to 1 in 1,000. If we're talking about oral sex, it's much lower than that, sort of 1 in 10,000 or less than that. So when we're talking about transmission, of course, we have to, the tools that we have and the way that transmission happens is we have to have two people. One person has to be living with HIV and one not. So what is it then that is the factors that dictate whether transmission happens or not in that context? So, and I'll go into it a little bit, but you know, my overall message is for the HIV positive partner in this context, it's all about the viral load. It's all about how much virus is present in secretions, whatever we're talking about. Of course, if we're talking about blood transfusions, then it would be what's present in blood transfusions. I'm really not focusing on that at all today, or needle transmission. But I'm talking about genital tract secretions, so rectal secretions, vaginal secretions, semen, saliva potentially for oral transmission, etc. In the HIV negative partner, it's all about susceptible cells. So it's all about where you're being exposed to HIV, are the cells around that can actually get infected by HIV if I do get exposed to HIV. So in the positive partner is really the easiest message. So this is looking at genital secretions now, and summarizing lots of work. On the left here, we have the risk of transmitting to your partner if you're in a discordant couple, and the amount of HIV that you have in semen. So the more HIV there is in semen, as you go over to the right, the higher the percentage chance that you're going to transmit to your partner each year. And if we look in female genital tract at vaginal secretions, exactly the same thing. As the amount of virus goes up, so the risk of transmission goes up. The good news is, and again, every now and then I'll put in some data from our lab, so I'm sorry, but if you put somebody on treatment, you know what happens. The viral load goes down in blood, and the viral load overall, certainly by the time you get beyond a few months, the viral load is almost always undetectable also in the genital tract. And in keeping with that, you know, the partner study, and I know there's going to be much more detail on that, but in a number of studies around the world, we've been looking at what is the risk of HIV transmission when I'm on treatment and my viral load now in blood has been undetectable for a few months. So again, we know from back here that means that the viral load in the genital tract is also going to be undetectable. And the answer is we haven't seen any cases. And just to highlight the new statement that came on World AIDS Day this year from Justice Canada and from the Attorney General in Ontario. So again, I've just cut and pasted two important bits from that. So in cases where we have sexual activity between serodiscordant partner, where one partner has HIV and one doesn't, the risk of HIV transmission is negligible, where the partner living with HIV takes their treatment consistently and has a not necessarily totally undetectable, but a suppressed viral load that they determined here to be less than 200. And then they say lower down, therefore consistent with Supreme Court of Canada jurisprudence, the criminal law should not apply to people living with HIV if they've not disclosed their status, as long as they maintained a suppressed viral load, i.e. under 200 copies, so that we should not be facing criminal charges in that context anymore, which is, I think, a big step forward. There's still more that can happen. I'm not the legal expert, but that is based on very good science, and you're going to hear about some of that science today in terms of the impact of treatment on transmission. So, okay, what about the negative partner? Obviously, many people living without HIV, they may not know the status of their partner. They may not know if or who they're going to have sex with today or on the weekend. And so what can somebody there do to protect themselves? So I think, you know, just to summarize, again, to put some themes to it, you can make the cells that are present where I might get exposed to HIV, you can make them resistant to HIV, and that's PEP and PrEP. A lot of the good tools that we have available now are based on HIV medications. And again, you're going to hear more about PrEP, I guess, from Isaac, and probably not as much about PEP, right? So PrEP is the pre-exposure prophylaxis, where I am already taking HIV medications before I get exposed to HIV. The PEP is the post-exposure prophylaxis, where I am taking medications after a known or potential exposure to HIV that might be high risk. I can remove target cells completely, and penile circumcision is a tool that, if the penis is where I'm getting exposed to HIV, as is in the cases of countries where it's predominantly a heterosexual epidemic, then that would be a way of reducing my risk. I'll share a little bit of data on that. I can reduce target cells that are present, perhaps by treating or preventing STDs, perhaps by changing the normal bacteria. I'll talk a tiny little bit about the microbiome, and I can protect target cells that are there by making immune responses that can protect potentially with an HIV vaccine. And again, we're obviously going to hear about that later on. So again, I won't go too much into the pre-exposure prophylaxis. I think everybody who is in the room really will know that there's very good studies that have been done recently in terms of implementation of pre-exposure prophylaxis, and that by taking, in general, a pill of Truvada every day, perhaps on-demand PrEP, where I may take that intermittently depending on when I'm at risk, and I think Isaac will probably touch on that, I can reduce my risk of acquiring HIV by 95%-ish, although there can still be cases of HIV transmission, even when I've been very careful taking my pre-exposure prophylaxis, my PrEP, if I happen to be exposed to a drug-resistant virus. And actually Toronto was the place where the first case of that was published by Darrell Tan, who again does a lot of work around PrEP and is not here, and David Knox at Maple Leaf Clinic published a very nice paper on that. This is just to remind you, and again, it's just a little cartoon. The little cartoon here says it's vaginal and cervical epithelium up at the top where somebody's being exposed to HIV, but it would equally apply if it was penile mucosa or rectal mucosa. The only thing I want to get out of this is after somebody has been exposed to HIV, you see it takes about a week where that virus is propagating locally in the mucosa before that virus gets out from that genital lining or rectal lining into the bloodstream, and infection becomes irreversible at that point. So during that week, if I'm able to put something in place that can protect me, i.e. post-exposure prophylaxis or taking medications after the exposure, that is still felt to be very effective at preventing HIV, probably about 90% plus effective, maybe not quite as effective as PrEP. We're never going to do a clinical trial in this context to prove that. So we usually assume, I usually tell people it's 90% plus. I don't know what Isaac tells people, but I think that the data aren't great. That's really based on some inadequate observational studies in humans and some monkey studies. This is just showing you data from Kenya. This is actually from the Kenya AIDS Indicator Survey a few years ago, but the latest data is still very similar. It's just showing you, if you look across Kenya, your risk of acquiring it, or being HIV positive, if you are circumcised or uncircumcised. And what you see is that if you are uncircumcised, given that there are tremendous behavioral differences potentially between communities that circumcise or not, your rate of acquiring HIV is much higher. And there's nice data saying that if you provide penile circumcision as a one-time HIV prevention tool, if the penis is where you're getting exposed to HIV, that reduces my risk by about 60%. But obviously, the penis has to be where I'm getting exposed to HIV. If I'm being exposed on the rectal mucosa, doesn't matter what's happened to my penis, that's not going to protect me against HIV. And there has to be a foreskin present at baseline. If I'm already circumcised, then obviously there's nothing I can do further to reduce my risk in that way. So I'm happy to talk about that. We do lots of work around immunology and foreskins. This is just like, the microbiome is very neat. Everybody likes talking about the microbiome. This is just showing you the microbiome is just the sum total of all the bugs that we all carry on our bodies in all parts of our bodies. And this is just reminding you that it's quite different. The oral microbiome, the skin microbiome, the types of bacteria that we carry in the genital tract and in the gut are quite different. And the type of bacteria that we have actually is an important determinant of HIV risk. And so don't pay too much attention to this. All we're saying here is what proportion of people have inflammation. And this was a study that was done in women where we divided up the types of bacteria present in the genital tract into 3 groups. This CST just means community state type. So don't pay any attention to what it is. The bacteria, no STDs present. This is just the bacteria you normally carry in the genital tract. You can divide them up 3 ways, and the type of bacteria that are present without any symptoms is a very important determinant of whether you have inflammation and more cells that are susceptible to HIV. Exactly the same thing holds in the penis. We look at the penile microbiome, and the microbiome is an important predictor both in the female genital tract and on the penis of whether a man gets HIV. We don't know as much about the rectum yet, but studies are being done on that. And HIV vaccines, again, we're going to hear about HIV vaccines. I think this is my last slide, and really, obviously that's the ultimate goal for biomedical prevention, because an ideal vaccine, which we do not have, is something that you could administer once or twice, that would give you long-term protection against HIV acquisition. You wouldn't have to keep remembering to take something every day. There wouldn't be a cost each day. I wouldn't be having to carry something around with me that can potentially be stigmatizing in terms of branding me as being somebody who is having sex or being at risk in any way. But I think we'll hear about HIV vaccines and where we're at. I think my short summary is don't hold your breath. I think we've got some great tools right now. We're working very hard on vaccines just because that is the gold standard of the way we should be preventing HIV, but we're not there yet. And I think we need to get down to zero, as Robert is talking about. We need to learn how to use the tools that we have while we try and develop, while JP and his team make that HIV vaccine.
I'm Isaac Bogosh. I'm one of the physicians over at the Toronto General Hospital across the street. I'm going to try not to get my eyes poked out from this thing. We're okay? We're good. Anyways, we're going to talk about HIV prevention with a focus on HIV pre-exposure prophylaxis. I know we're supposed to reserve questions at the end, but really, this is chill. This is informal. Stop me at any point along the way if you have any questions, and I'll leave plenty of time at the end of this if you have any questions, but I know you want them at the end. As Rupert kindly pointed out, there's several different ways we can prevent HIV. One is HIV pre-exposure prophylaxis, and essentially the theory here is someone doesn't have HIV, but they might be at risk for it. We put them on medications, and the drugs build up in their body, and if those people are exposed to HIV, great, they don't get it. And it works probably about 99% of the time. So it's really effective, and it's a game changer. And this is called PrEP, or pre-exposure prophylaxis. It's really interesting because a lot of the early studies for pre-exposure prophylaxis started coming out in around 2011, 2012. And this was really, at least in the United States, it was rapidly integrated into routine clinical practice. Now, in Canada, we do things a little bit slower. We're a little more methodical than our friends and neighbors to the south, and it took a long time to scale this up here. And I would still say it's still taking a long time. What we did was we developed a dedicated HIV prevention clinic here in downtown Toronto on the 13th floor of the Toronto General Hospital. We'll put an asterisk beside that because I want to talk about that in a second. And this really focuses on HIV prevention. So it's not just PrEP, although PrEP is what we do a lot of, and we have probably close to 400 or 500 people on PrEP now, so it's Canada's largest, and it's a busy clinic. It's Canada's largest PrEP clinic. We also do HIV post-exposure prophylaxis, so we care for people that have had HIV exposures. They come in, and we can put them on medications after an exposure to ensure that they don't get HIV and they get the appropriate care that they need afterwards. And then, of course, we care for what I like to call people that are in between. They might not be on PEP, they might not be on PrEP, but they're what we would consider high-risk individuals for whatever reason, for a variety of reasons, depending on lifestyle or circumstances. And we like to keep tabs on these individuals and see if there's anything we can do. Now, the clinic and the approach to these patients, of course, it's not just giving people drugs like Halloween candy. This is a much bigger issue, and we like to think of this as holistic care. And we appreciate that people come in from various psychosocial backgrounds, from various circumstances. And this is, people throw around the term interdisciplinary care, but HIV prevention, especially PrEP, really is interdisciplinary care. There's physicians involved, there's nurses involved, there's counselors involved, there's social workers involved, there's pharmacists involved. We have access to resources in the community for drug cessation programs, alcohol programs, harm reduction programs. We have a lot of patients who are on crystal meth, and we appreciate that there's lots of drivers that will put people in, that might place people in high-risk settings. And, obviously, medications are one component of reducing this, but we also don't turn a blind eye to the other aspects of care and really look after the whole individual. Now, what we saw, if you look at the natural history, especially over the last few years, HIV prevention, especially PrEP, was really exploding in the States. You've got ID docs, HIV specialists, and primary care providers providing PrEP care. And in Canada, like I said, we were really slow. And there's, even if you look around today, in Toronto, in Ontario, and certainly in Canada, it's remarkably challenging to find people who prescribe PrEP. And we have a dearth of HIV prevention practitioners. And, you know, there's a variety of reasons why that is what it is, and it is getting better. And it's getting better for a couple of reasons. In Ontario, I can think of 3 key things that are helping at least improve access to care. Number one, initially the drug was very expensive. We used Truvada, which is a brand name for 2 medications mixed into one, and it was about $1,000 a month, maybe $1,100 a month. Unaffordable unless you had private insurance or you were filthy rich, okay? But now there's generic forms of Truvada, so there's generic forms of this, and it's covered by Trillium. So the province will help supplement the cost for people that can't afford it. And this is just fantastic. I mean, the province really stepped up. There was a lot of advocacy by people up at the table, myself, and certainly people in the audience, to really push the provincial government to cover it. So you've got generic forms, and it's covered by Trillium. So for people who might not have the means to have access to it. And the third component is several people in this room were involved with creating what we call HIV prevention guidelines, which is basically a toolkit for primary care providers, specialists, healthcare providers, but basically a roadmap, a rule book, a playbook, if you will, of how to provide quality HIV prevention care. And these are freely available, and it's widely available, and anyone who wants to provide PrEP care can do so now. There's an easy document to read on how to provide it. The drugs are available, and the drugs are accessible. So we're going to start to see more and more scale up. And that sort of segues to my next point. You know, we have a very, very busy clinic on the 13th floor of the Toronto General Hospital. But like, that's insane when you think about it, right? That's insane. We're talking about access and really ensuring that the right people have access to the right HIV prevention modality, and we're just not accessible. Okay, this is, you know, for people who might inject drugs, for people who might have concomitant mental health issues, for people who might not have the wherewithal to make it to clinic and don't have a partner or a person who looks out for them to bring them to clinic. We're not the most accessible. And really, the goals of providing HIV prevention care, not just in Toronto, but really countrywide, is to get HIV prevention into community settings. Sexual health clinics, primary care clinics, public health clinics, even practitioners on the streets as well, and really ensuring that there is access to people who would probably most benefit from this. So, you know, for sure, there's a complete selection bias of who we're seeing in clinic. And, you know, I'm still proud of what we've done, and we're certainly caring for a very large cohort of people who are at significant risk of HIV, but there's a lot more work to be done. And now that we have the toolkit and the drugs that are available, now the next steps are really bringing HIV prevention, PEP and PrEP, out into community settings where it will be more accessible for those most in need. I think I'm going to stop there, and I'm happy to have any discussion or take any questions if anyone has any.
I guess I'm feeling less forgiving about Ontario government policy in this area, because we saw on January 1st that British Columbia brought in a blanket PrEP program, so everyone who needs PrEP is covered. We know that in Quebec already has pharmacare, so PrEP is covered for anyone through pharmacare. Ontario is the laggard in this country because people between the ages of 25 and 65 are not covered except by spottily. And that's exactly the group. You look at Abby's figures, this is where the spikes are. This is where the infection is occurring. Ontario seems to be asleep at the switch when it comes to PrEP. And as you mentioned, there's massive scale up happening in the US.
Yeah.
Why are we so backward?
So I have 2 things to say about this. Number one, in terms of the Ontario government, as you know, I'm not a government official, and I'm not even going to pretend to understand how government works. And I was at the ministry several times advocating, showing our data, and really promoting PrEP coverage. And I would agree with you in that A, it's not perfect. B, it's far from perfect. But C, it is a tremendous step in the right direction. Doesn't mean it's the last step, but it is a tremendous step in the right direction. And I can tell you firsthand, we are already seeing significant positive benefits as a result of that policy change. Now, does that mean you let your guard down and stop fighting the good fight? No. Okay, there's still work to be done, but this is a tremendous step in the right direction, and we're already starting to see the benefits shortly after. So that's point number one. Point number two, I don't know why there's a reluctance for this to be taken up by A, primary care, B, public health clinics, C, sexual health clinics. I don't know. And I got to tell you, my unofficial part-time job over the last 3 years is going on speaking tours to clinic after clinic after clinic all throughout Southern Ontario with a playbook. Here's how you do PrEP. Call me. Here's my email. Here's my cell phone. Let me know if you need anything at all. It is not that hard to do, and you can really provide fantastic care, and it's not hard to do this. And even providing my cell phone for backup. Like if you have any questions and you're seeing a PrEP patient, give me a shout. And there's been a tremendous reluctance to do so. I think over the last few months, we've seen a shift in the right direction with the guidelines out and with the drug becoming more accessible. But as you point out, there is work to be done. I don't think we haven't achieved success yet, but we're certainly closer to it than we were before. Yeah.
I have two questions. The first is, what are the what are the risk categories that are considered for someone to be eligible for, mostly PrEP, but also PrEP?
Yeah.
And the second is, if we are bringing it into the community space, how can we make it more accessible to people who may not be documented or may not have valid OHIP cards?
Yeah.
Because especially if we are working in sexual health clinics, for example, where I work, we do come across people who are, in those circumstances.
Yeah, so two good questions. So basically, number one, who's eligible? And B, how do we get people who are really the most marginalized of marginalized? So who's eligible? I mean, everyone, you know who's eligible, right? People who are having multiple ongoing exposures to HIV, be it sex, be it needle, be it other. So, just calling it how it is, we see a lot of men who have sex with men in our clinic. Yep, we see commercial sex workers, we see trans commercial sex workers, we see an occasional injection drug user, but it's mostly men who have sex with men. And of course, that is a complete selection bias of where we are geographically. And we know that there's other people who are at risk with different risk factors elsewhere in Toronto. So that's point number one. Anyone who's at risk, who has an ongoing risk for HIV acquisition, is probably a good candidate for PrEP. Now, I don't have to get into the nitty-gritty details about who would be and who wouldn't be, but that's a general term. Second thing, undocumented people, let's just call it the most marginalized of marginalized individuals. How do we get them on PrEP? Well, really, you need a good PrEP provider. I'm looking at a few at this table, maybe even me. But like many of us who are in this line of work don't care if you're documented or undocumented, if you have OHIP or you don't have OHIP, if you are from this risk factor or that risk factor. Like many of us don't care. If you come into clinic, we see you and we make it happen. We have, and this really goes back to having fantastic interdisciplinary care. So meaning some of the clinicians, lean heavily on our social workers to find good resources in the community to ensure everyone has access to the resources that they need. And I can't thank our social workers enough because they do miraculous work. And I can tell you, I can't speak for other PrEP clinics in the city or in the province, but I can tell you at ours, no one goes without. If you have a need, we will find a way. Sometimes we bend the rules, but we find a way.
Can I add to that?
Yeah.
Just as a resource that is accessible sort of in the community as well, because it is a bit of a bottleneck, right? And being able to, particularly getting coverage for people. I mean, we're all willing to waive our fees and that's fine, but it's hard for people to actually continuously be able to pay for meds and then not do stuff to kind of try to make their meds last longer, right? Which is a risk then in terms of developing resistance or actually acquiring HIV while you're on your PrEP. So the AIDS Committee of Toronto has a PrEP access coordinator. So if you call the AIDS Committee of Toronto and ask to speak to this PrEP access coordinator, it's sort of like how in your clinic, because you have access to the social worker, to Andrea, she's able to kind of do that. In the community context, if you don't have access to social workers, or if the social workers that you work in your context are not necessarily familiar with HIV and medication access, that PrEP access coordinator at ACT can help people try to navigate. We're still trying to patch things together, which doesn't solve the systemic issue of coverage for drugs in Ontario, but they're often able to help people who otherwise would not be able to access drugs.
So there's a way.
Sorry, I'm going to step in for a second. So I'm currently, and I was going to speak at this at the end because Sharmista and I are last. So I'm currently part of a study that's actually looking at drug coverage in Ontario and how people pay for medications. And we're finding that there's huge challenges. And so even if someone can get Trillium or can be on ODB, you still have to pay these massive deductibles. You still have to pay these co-pays. And we're talking about the context in Toronto, and it is great that there's at PWA, there's also a treatment access coordinator. But what we're finding from the people that we're talking to is that they didn't even know that existed. And often the physicians themselves that they're seeing, particularly outside of Toronto, don't know that those services exist. And so there's a huge gap, and people are struggling. And this whole issue of pharmacare and drug coverage, maybe it's less of a problem in Toronto. It still exists in Toronto. But once you go outside of Toronto, it's way worse. And
But
it's something that we can't forget. So
essentially
the
what we
access
need,
is
though,
important.
Yeah, no, of course. I mean, this is one of the major issues. And again, I'm not saying this is a perfect system. It's far from it. It's much easier. I mean, look, before this happened, we were practicing in the shadows, right? PrEP, we weren't even supposed to be prescribing Truvada for this, and we've been doing it since 2012. We weren't supposed to be using Trillium. We kind of were when we, you know, and this legitimized what we were doing for 4 years. So I mean, you know, it's certainly a step in the right direction, but it's not the end goal. Yeah. The other thing is we need better like as you were pointing out, we need obviously better coordination. And you know, I think. I can't stress this enough, is the interdisciplinary nature that people at risk for HIV really require, and the people who are in tune with what resources are available in the community are invaluable. Because I mean, the clinical side is relatively straightforward, right? You're at risk for HIV, go on Truvada, come see me every 3 months. We'll treat your sexually transmitted infections. Do the right test, make sure you're healthy, see you in another 3 months. It's the access to resources that is the challenge. That's the challenge.
Well, we're actually out of time, but I
All
still
right.
have another question for you anyway. So you actually hit one of the nails on the head that's interesting to me because, yeah, the UHN clinic is fantastic, and so is Isaac. And you were talking about this speaking tour you have to go on, you know, to have other people be as good as you are. And, you know, that to me is a problem, that it's not a normalized part of care as many other wellness options that a good person who has graduated from medical school should be able to provide to their patients, rather what they come in the door with. And so the fact that we're here, we're so specialized, we're so, you know, clever and committed to HIV care, that's important, but I also kind of look forward to the day when it'll be just another thing, and we're far from that.
Yeah.
Now, so when you say you give PrEP to, you know, whoever wants it, but I think we do have to remember what Abigail was saying, you know, and where are we going to get that incidence bang for the buck? And maybe this is something that you'll be answering next year. How many of the people, in terms of getting that number down, not just giving more pills, are we not reaching compared to how many people get it from your clinic or your clinic? If we look at everybody around the province who, as the guidelines say, I hate to use that word, should be getting PrEP, but who would, the word should is in terms of that incidence reduction. I don't know, we know that number, but that's a gap.
I'm going to ask Sharmista about that. No, you're right. I mean, like, who's at risk? And who's eligible for PrEP versus who's on PrEP. And I can tell you in the early days, when word got out that we were providing PrEP, I mean, people were driving in from, we have people drive in from 4 hours away to be seen in our clinic, and our waiting list was 3 months long. And now, you know, we're still seeing that, it's just less and less, because there is some increased, a few providers that are dealing with this now.
Hi, everyone. So as Robert said, I'm Taylor, and I'm actually a graduate student in the lab of Dr. Jean-Philippe Julien in the Department of Biochemistry at University of Toronto. So I have a little bit of a different perspective than everyone else on the panel, and it's been really great to hear from the speakers so far. But what I do is actually basic research. So I'm working towards new candidates that might maybe become a vaccine, and what do we do that might work down the line. So as it was alluded, an HIV vaccine, it's far away, but there's still so much important research that's going on right now, and we're getting closer. So yeah, basically, how and why do we need an HIV vaccine? So Abigail did a really good job of kind of introducing what I want to say here, and that's incidence rates, not only in Ontario, but also globally, aren't going down the way that they should be with the current prevention methods that we have now. And if you look globally, in 2015, there were 2.1 million people who were newly infected with HIV. And this is only a 6% reduction in the number of new infections since 2010, so over 5 years, despite major investments in current treatment and prevention programs that have been implemented. And there's many reasons behind this. Especially in low and middle income countries, involved with adherence, socioeconomic barriers, pathogen reintroduction, implementation limits, as well as stigma and violence. And while these factors do play a huge role in low and middle income countries, they do play a significant role here as well as in other developed countries. And globally, only 40% of people living with HIV have access to antiretroviral therapies. And that's a huge gap in prevention care that needs to be addressed. And there's a lot of mathematical modeling that goes on, and I'm sure it'll be talked about a little bit later, as well as what's been done so far, that can attempt to predict the number of new infections in the future. So I'm going to show you a little bit of data, and if we skip ahead to the year 2070, we can predict the number of new infections either with or without a vaccine. And this is with a vaccine that's 70% efficacious. So it prevents HIV 70% of the time. So it's not 100% effective. So if we keep going the way that we're going with current prevention methods, in the year 2070, we'll have 1.7 million new infections globally. And like I said in the previous slide, in 2015, we were at 2.1 million. So this really isn't a significant improvement from where we are now. However, if we implement a vaccine that's 70% efficacious, this would drop this number down to 257,000 new infections per year. Now, if we do a 50% scale up of prevention methods, without a vaccine, we'd be at 1 million new infections, but with a vaccine, we'd be at 184,000. And if we scale this up even more towards the 90-90-90 goals, without a vaccine, we'd be at 547,000, which is a huge reduction from current trends. But with a vaccine, we'd be at only 122,000 new infections. And this would be a huge progress towards the goal of 0 new HIV infections. And so it's very obvious when you look at numbers like this that the best way to prevent HIV would be to combine the tactics that we currently have with the scale up with a vaccine that shows some efficacy. So how close are we really to having an HIV vaccine? This kind of comes down to the number of clinical trials and what's going on in the research field at the moment. So there's a lot of preclinical experiments and vaccine candidates that are being developed, and the ones that are good are then funneled into clinical trials. And just really briefly, because I'm sure most people in the audience have some concept of understanding of how clinical trials work, there are 3 different phases, phase 1, 2, and 3, where phase 1 is done in a small group of healthy volunteers. Phase 2 is generally done in a larger group of affected individuals, and phase 1 and 2 both assess safety of the therapeutic as well as efficacy. So does it work? Phase 3 is then a huge scale up in comparison to phase 2, so this is generally thousands of people, and it also ultimately gets down to the question of, is this going to work in a population? So currently at the moment we have 24 clinical trials in phase 1, 5 that are phase 1 and 2, 4 that are in phase 2, and only 1 that's in phase 3. And what you notice when you look at these numbers is firstly we need to keep funneling new vaccine candidates into this pipeline. Because if we start with 24 but only end up with 1 in phase 3, it's going to be a really long time before we end up with an effective vaccine. And yeah, we do have one phase 3 trial going on right now, and this is essentially a repeat of the RV144 trial that was done in Thailand several years ago that showed a 30% efficacy 3.5 years after getting the vaccine. And this was on the barrier of statistical significance. So basically, this phase 3 trial is aiming to repeat that in South Africa, where incidence rates are higher, to see if that efficacy that was observed is real. So even though we have this phase 3 trial, it showed 30% efficacy several years ago, and it's nowhere near the 70% efficacy that we would need to reach those goals that I was talking about earlier. And if you have any more interest in this, there's clinical trial data available, as well as you can talk to me. So if we go back to talking about kind of the basic research that funds this pipeline into clinical trials, there are several things that need to happen for us to create a successful vaccine. And a lot of that comes from our basic understanding of how HIV infection works and how the immune system responds to it. And almost everything that we know now about HIV infection comes from the studying of samples from HIV positive people who have given us our samples for study. So it's a huge community network that has allowed us to get to where we are, and this has been going on for decades. And all of this information that we know then gets funneled into immunogen design, so designing a vaccine candidate that might work, as well as immunization strategies. So when we vaccinate, by how much, what the schedule looks like, that kind of thing. And then if we have something that looks positive, then we move into animal models, see does it work? And if it does, then into clinical trials. And if not, we kind of go back to the beginning. Why didn't it work? And start through this pipeline again. So at this point, you might be wondering, why is HIV so difficult to vaccinate against anyway? Why is this taking so long? And before I get into that, I just really quickly want to talk about what a vaccine is. So it introduces a safe form of a pathogen into your body, whether it's a fragment or an entire pathogen that has been inactivated. And this ultimately teaches your immune system how to react to the pathogen if you ever come in contact with it in your life. And by teaching your immune system to do this, then you're able to prevent infection. So basically, you teach your body how to fight it before you get infected. And there are several different types of vaccines. Ones that range from, I don't know if this works. Yeah. Ones that range from subunit vaccines, so just small components of the pathogen, to actually live pathogens. And when you look at this spectrum of different types of vaccines, there is a trade-off. So the things that tend to work the best are also the things that are the least safe. And the same thing on the other end of the line, where things that are safe don't really tend to get the attention of your immune system enough to actually produce a protective response. And then on top of those problems, there are several problems that are specific to HIV. So as you might know, HIV is highly variable, it is very diverse, and it's really hard to make a vaccine that would be able to combat all the different types of HIV that we see. And then on top of that, HIV is actually surrounded with a shield of glycans or sugars that protect it from recognition, as well as protect it from being targeted effectively by our immune system. So this makes it a really tough target for a vaccine. So before wrapping up, I just wanted to give you a little bit of a perspective about what my day looks like. So I am, like I said, a basic researcher, so I spend a lot of time at my bench, which is what is shown here, trying to make molecules that look like these. So this has components of HIV, which are the purple things, as well as other components that are trying to basically get the attention of your immune system. Because if you just give the purple trimer, which is actually what's in vaccine trials now, it doesn't work well enough, basically. So to make these molecules, I first start in tissue culture. So I actually work with human cells that I kind of give an instruction manual or DNA that make these molecules for me. From there, I harvest my cells and I purify my molecules so that I can do more studies with them. So kind of assess efficacy, or like whether they bind the things that they should and whether they have the correct properties. So I go from a 200 ml culture to about 500 microliters, so half a mil. And then from there, I can see whether or not these have the properties they should and whether or not they look the way they should. So I use microscopes like these ones to actually look at these on a molecular level. So these are actually individual copies of the big one that's shown there, but in real life. And then from there, I pass these off to my wonderful collaborator, Tina, who's sitting in the front of the the room today, and she's an immunologist. So she actually assesses whether or not these can activate the immune cells that we care about. And if they can, then we can move into animal models, which is hopefully where we're headed next. So with that, I just want to thank all of you for coming today. It's a cold Wednesday evening, and it means a lot that you guys are here. And as a researcher who doesn't really get the opportunity to leave the lab very often, it's really humbling. And to get into the community, I leave the lab. It's really humbling to be here with you guys tonight. So, yeah.
Does anybody have a question from the audience?
Just one other thing. I also want to thank Robert. He sits as a consultant on our HIV grant, and he kind of acts as like a community liaison between the community and the research, which is really important, as well as Bebin, who did a whole bunch of the planning tonight.
I'm Malika Sharma. I'm a HIV physician here in Toronto. Thank you so much for inviting me to speak tonight. So I'm going to talk about a bunch of different things. And so really what I'm going to talk about is HIV prevention in the current era of U equals U, or undetectable equals untransmittable, which is what people have been talking about a lot lately. And I'm going to kind of walk us along a little bit of a path to how did we get to this U equals U campaign, starting from the Swiss statement, the Canadian consensus statement, the partner study, treatment as prevention, and then U equals U. And then I think something that's really important to talk about is who is left behind by or despite these advances and in these campaigns. And then the last little thing I'm going to talk about is, it's not a little thing, is the issue of HIV disclosure in Canada. Because I think that as we walk towards U equals U, and Rupert already kind of alluded to this, it's important for us to think about what does that mean in the context of a country that has criminalization and disclosure laws, and how are those laws interpreted, and how can the U equals U campaign lead to confusion? So the path to U equals U, the very first sort of bit of information that I'll share is the Swiss AIDS Commission statement from 2008. So this is sort of the first time people started talking about this idea that people living with HIV who fulfill certain criteria are sexually non-infectious. And those criteria included that the person was under the care of a physician, was taking antiretrovirals, had been undetectable for at least 6 months, and they hadn't had any other sexually transmitted infections at the time. That statement was not without controversy, and part of the controversy is that all of those criteria have to be met, and sometimes you don't know whether that's the case, right? You may not know that you have a sexually transmitted infection, particularly if it is without symptoms. And then there's also a discrepancy that we know in some of the data around you can have an undetectable viral load in your blood and not necessarily in the genital secretions. And so there's been a lot of discussion around, well, how true is this really? And so even though the statement came out in 2008, it wasn't really until 2016 that we started talking about U equals U. So what happened in the interim? Well, a few years after this, many folks in Toronto actually came out with, or in Canada came out with a Canadian consensus statement on HIV. And this was specifically in the context of criminal law. So if you think about the final sentence of this document, the people who developed this document said, "We developed this statement because we have a professional and ethical responsibility to assist those in the criminal justice system to understand and interpret current medical and scientific evidence regarding HIV. We are concerned that miscarriages of justice may result when such evidence is not correctly understood or interpreted." And I think the impetus behind this was really an understanding in the medical community that probably U does equal U, right? Even though we didn't have all the data at this point, the data that we did have really suggested that that was the case, and people were being prosecuted in a way that didn't necessarily reflect true risk. And so this document was created as a way of trying to provide some evidence to support a more, I guess, evidence-based approach to criminalization, not because people agreed with criminalization, but recognized that it was being kind of done in a way that was very problematic. And then after that, a bunch of stuff happened that really, I think, pushed us towards U equals U. So this is the study from 2011 that the HPTN 052 study that really started this conversation around treatment as prevention, right? And in this study, what they basically did, I'm not going to get into the nitty-gritty details, but they looked at people who were infected in serodiscordant or magnetic couples, right? So one person's positive, one person's negative, and they either started people right away or they waited until people reached a CD4 count of less than 250, right? Because we used to do that. And what they were really looking at virologically linked transmission. So did starting early rather than waiting to start lead to any differences in HIV transmission? And it did. So transmission was reduced by 96%. There were 2 linked transmissions in total after starting antiretroviral therapy. One of those was in the immediate arm and one was in the delayed arm. In both of those situations, they likely occurred either right before antiretroviral therapy was started or right after it was started and before it could actually sufficiently suppress the virus. So this further supported the idea that probably once you're undetectable, you're untransmittable. There was also a systematic review in 2013 that looked at all the data up to that date and said, well, what is the risk really? And the risk was really 0, right? And so I think the challenge has been, and there was an interview recently that was looking at a lot of the semantics around this, right? 0, negligible, almost 0, right? Like all those words kind of sound the same, but they're not exactly the same. And I think they reflect a bunch of different things. I think that they reflect some degree of hedging on the part of clinicians because we're always really scared to say 0. They also represent, statistically, just this idea of confidence intervals, right? So Rupert alluded to the idea that not all sexual acts are equal in terms of their risk of HIV transmission. And so 0 is 0, right? But the window around that 0 changes for the sexual act. So that window around the 0 is slightly larger, for example, in receptive anal intercourse than in insertive anal intercourse, and those are larger than in penile and vaginal intercourse. And so it's really hard to have these nuanced conversations about 0 in a way that kind of makes sense and in a way that is practically actionable for people, right, in their real lives. And so I think that's something that certainly the field has been struggling with, but I think people in the community and people who just want to have like regular sex lives are also struggling with. This study from last year, which Rupert also alluded to, is the partner study. And part of the impetus for this study was in all of the studies up to this point, including the treatment as prevention one that I'd mentioned already, people were encouraged to use condoms, right? So that was kind of part of the counseling, and people were told, like, you need to use condoms, and this is what you need to do. But this study recognized, well, that's not necessarily what's happening in real life. So what about, the point of U equals U is, well, do you need a condom then if you're actually untransmittable? And what does that mean for people's actual decision-making of should I use a condom or not? So for this study, as an entrance requirement, you actually had to not have used a condom in the last 6 months. You had to be having condomless sex. And this study looked at both couples who were men who have sex with men and heterosexual couples as well. And what they were asking is, what is the absolute risk of HIV transmission through condomless sex if you have a suppressed viral load? So a very practical question, and I think that's partly why people were really excited to see the results of this, right? Because this is what people are asking us in our offices, and this is what people who just want to have sex in a way that doesn't feel so scary wanted to know. And so what this study found was there were 11 HIV-negative partners who became positive over the course of the study, predominantly in the group who were men who have sex with men. Of those 11, 8 reported condomless sex with other partners. So only 8 of the 11 reported that. However, none of those transmissions were phylogenetically linked, meaning none of them were actually linked to the partner who was in the study. So the HIV came from somewhere else. So the within couple HIV transmission rate of 0, i.e. the person who is known, right, the HIV positive person who is known in this study to have an undetectable viral load did not transmit. So the within couple transmission rate was 0. But again, as I was mentioning, the wiggle room around that 0 varied depending on the sex act. And so I think that still has led to some nervousness on the part of clinicians to say, well, 0 is 0. I know Tony Fauci, for example, in a recent interview was like 0 is 0. And I think practically 0 is probably 0, right? It's just, I think, going to be hard to find clinicians who say that. And so this has kind of led to the U equals U campaign, which has been really since mid-2016, people have started talking about this. It stemmed from the Prevention Access Campaign. And you can see this screenshot from the Katie document on U equals U. So the evidence is if you are HIV positive, take treatment and maintain an undetectable viral load, you can have sex knowing that you won't pass HIV to your sex partner. In short, when HIV is undetectable, it's untransmittable. This is really not that different from the statement in 2008, right? It's taken us a long time to kind of come back to this. But one thing that I think is important is, and I don't actually disagree, I think U probably does equal U, but does it apply to everybody? And I think this is where it's really important to talk about this idea of gaps and who falls through those gaps. So this is just a reminder of the HIV cascade of care, which we've all seen, and we've seen today as well, right? So the idea that there's people who are diagnosed with HIV, a small, if that number is this, then a smaller proportion are actually linked to care, even less retained in care, even less actually on antiretroviral therapy, even fewer of those actually taking their antiretroviral therapy, and even fewer of those virologically suppressed, right? And the goals, of course, are 90-90-90, right? And the goals are to get everybody, to get these lines level so you don't see this steep drop-off. But the drop-off does exist, right? Like, so in our current environment, this drop-off does exist. And this drop-off, part of why it exists, we've already alluded to, right? So drug coverage is a big issue. So in places where you walk in the door, you got your diagnosis and you walk out with antiretroviral therapy because it's covered for everybody, you're a lot more likely to be able to get more people suppressed, right? Versus an environment like ours, where often there's a bit of a gap between when we first see a patient in clinic, we kind of cobble all their drug coverage together, and then we have them on something sustainable that they can be on thereafter. Even beyond that, there's a lot of people for whom this cascade looks very different. The next few slides, I'm just going to show you examples of this without getting into all the nitty-gritty details, but they highlight some important areas, for example, where while U equals U, not everybody can get to U for a variety of systemic and structural factors, right? So for example, incarceration, right? Interestingly, you'll see that there's areas where way more people who are incarcerated, the white lines during incarceration, more people are linked and retained in care because they're incarcerated, right? So they're in a confined space. And then look at the drop-off once they actually leave care, right? So, once they leave the prison context. So there's lots of structural barriers for these folks. Similarly for youth, these are huge drop-off rates, right? So what are the barriers at each of these levels and each of these steps around being able to stay on therapy? Similarly with maternal health, there's lots of transitions in the pre, peri, and postpartum period where women are often started on therapy in the context of their pregnancy. Everyone's focused on making sure baby stays negative. What happens after that? What are some of the barriers that women continue to experience and potentially go off antiretroviral therapy after pregnancy? And then commercial sex workers. There's actually just not a lot of data, and you can see Dr. Mishra's reference here in this paper as well. And so there's groups for whom U may not equal U. I'm going to spend the next couple of slides, and it's the next couple of seconds, talking about this campaign this document that was put up by the Women's HIV/AIDS Initiative here in Toronto that really highlighted this. So they said, if U equals U, asterisk, what does it mean for the people who live in the asterisk? So for example, does U equals U apply to breastfeeding or chest feeding? No, right? U equals U really just applies to sexual transmission, but when we talk about U equals U in this kind of blanket way, it can be really confusing for people or unclear, right? When does this apply? It does not apply for breastfeeding, and it doesn't apply to people who use drugs, right? Like it's not talking about needle transmission, it's only talking about sexual transmission. And then the part that I've alluded to already, which is that not everybody is able to achieve undetectable viral loads. For example, we've already heard about women and some differential outcomes in terms of time of diagnosis, right, from time of infection. Women are also less likely to achieve undetectability because of poverty, housing insecurity, violence, immigration status, racism, food insecurity. And then there's also, again, this is from the same campaign, the very real risk that this creates a hierarchy of undetectability, right? So, for example, around criminalization, we have to be very careful in our messaging as clinicians, our messaging as community members, and as advocates that we don't create a system where we're saying that, well, if you're undetectable and therefore untransmittable, you shouldn't be criminalized. But the corollary to that is not that if you are detectable that you should be criminalized. Like those things are not equivalent. And that kind of brings me to the last point, which I'm not going to spend a lot of time on, and I appreciate that Rupert brought this up already, that I do think U equals U has some implications for HIV disclosure, and this year has seen some positive changes in terms of our laws around what equals realistic possibility that you'll pass HIV onto a sex partner. This is from HALCO, so the HIV/AIDS Legal Coalition of Ontario. And it's a pamphlet that they put out, or a document that they put out in May of 2013. It hasn't been updated since. But it brings up some really important points, and I recommend it to people because even for me, like as a clinician, it really helped me understand how I should counsel my patients. But things like disclosure actually means the actual words. Like you can't assume that because someone saw it on your Grindr profile that they read it. And that I have it in my Grindr profile doesn't stand up in a court of law. Like you have to have said the words, which is things that I didn't realize. I'm not going to spend too long talking about disclosure other than to say that we have criminalization laws in Canada. We have to disclose for a variety of reasons. I think that this has major implications for our ability to get to zero, right? So I think HIV criminalization makes a really good reason to not get tested, right? It has public health consequences. It perpetuates stigma at individual and societal levels. It also just complicates sex and creates fear, and I think that that's crappy, to be honest. And it also makes it difficult to leave abusive relationships, creates the potential for increased violence within those relationships, and it also has the potential to erode patient and provider relationships. And I think that even still, despite U equals U, my worry is that people interpret that in, the Supreme Court is saying like, okay, U equals U, you don't have to disclose in these particular contexts. My worry is that there's still some wiggle room around what is a realistic possibility, and I think that it still leaves the door open for criminalization of people who are undetectable. So that is a concern to me. So that's all I'm gonna say.
Malika.
I know I have too many opinions.
And Rupert. Given an imagine an undetectable person, given an infinite amount of sex and an infinite amount of time, does U equal U?
Statistically, probably not, right? So statistically, no.
I mean, again, it always comes down to semantics. I mean, I know Bob, Bob from Positive Life or whatever, we're always having this debate. So, I'm happy to go with, I'm happy to say there's no realistic possibility of transmission. That's different to saying that transmission is impossible. Right. So I think as a clinician or as a scientist, I can never say something is impossible. Like if you ask me, is it possible that a raccoon will fall on my head and break my neck as I walk out from the building here? Yes, of course it could. But, I think that's extremely unlikely, and it's not going to stop me in any way from walking out the door of this building and not looking up as I go out. So I think that, that's a semantic thing that is annoying, but it means that we can absolutely, I can say to my patients in my clinic, don't, if you're trying to get pregnant or whatever, like if you're worried about criminalization, don't worry about it. You're on treatment. You're undetectable. You're not going to transmit. I can say you're not going to transmit. Now, if you say to me, is it possible in some universe that it could happen? It's not impossible, but it's so negligibly, it's so negligible. We have not seen it yet, and it's a negligible possibility. Abigail wants to wade in.
Well, I think that we end up diving down into this discussion of statistical probabilities, but that's not how people make their decisions. Yeah. And there could be an earthquake in Toronto right now, and this wouldn't be a good building to be in, but what are the chances of that? We didn't decide that we weren't going to come here today because there's some negligible chance of an earthquake. So I feel like the dialogue ends up going down this pathway where we're saying, given the 10,000 sexual encounters, what's the probability? Right? It's causing an issue when we communicate with the community because, at the end of the day, we know there are a lot more risky activities that are going on and policy changes and program issues that need to be solved other than just thinking about what is the lowest risk activity that could be going on that this small population, which we know is the least likely to transmit. And so just one thing to add here is because I think it was a really good point that Malika mentioned, which was there was 11 transmissions that occurred, not from the partner who they knew had HIV. So when you're having these observational studies, if you just looked without doing the phylogenetic analysis, you would have said there was transmission. Yeah. Because you don't know what actually people are doing, and not all those people said it was from another partner. Yeah. And so without having a study that really looks at the phylogenetics, you would have came up with the wrong answer.
Absolutely. And I think just one other piece to that is I really appreciate you saying that piece of this is not how people make decisions, right? In their day-to-day lives. And so I think functionally, U equals U. And I think I'm much more concerned about, let's get people who are undocumented access to let's get everybody access to medications, right? Like, let's get everyone to you, right? Like, let's do that and prioritize some of those goals. And then the other piece that I'll add to that is all of this U equals U means that people have to actually stay you, which means they have to not have concomitant syphilis, gonorrhea, chlamydia, and that means we actually have to test for all of those things in all the appropriate sites, right? So testing at all potential sites at a regular interval, and so that's like another soapbox that I can get on, that's not necessarily happening in all places. And so if we want to talk about U equals U and actually make it happen, then I think that as clinicians, we also have a fair bit of work to do to kind of make sure that U truly does equal U.
So my name's Sharmista Mishra, and our lab works on mathematical modeling, and we kind of got a shout out a couple of times during the panel today. So what I'm going to talk about are 3 principles which I think apply heavily to thinking about HIV prevention, and that's because they apply for any infectious disease, any epidemic, any outbreak, and these 3 principles I think are important when thinking about each of these biomedical tools, and then as Beth is going to talk about what next when you really think about implementing biomedical tools, and what does that mean when you think about taking it up to scale, and how do you do that? So the first is, individuals are not mutually exclusive. We're all connected, and in the case of thinking about HIV, we're thinking about sex, and we're thinking about sexual networks or injecting networks or other networks. And which means that essentially when you think about one infection, and particularly preventing one infection, you're thinking about a ripple effect or a downstream effect with respect to preventing one infection is actually not what you're doing. You're preventing more than that because communities are connected through sexual networks. And so what that means is that pretty much, and the role of mathematical modeling in a lot of the work that people have done around prevention has just been to help estimate, well, if we implement this tool, so, Taylor talked about sort of what if we did have a 70% efficacious vaccine, what if we did scale up 50% with respect to the tools we have, what impact could we have? Well, if we assume that everyone is mutually independent, no one's connected through sex or injecting, et cetera, we might see some population level impact, but knowing that people are connected means that we actually get a larger impact than what we think our efficacy data would tell us. And so the principle of this is really around herd immunity, which really came from the vaccine world, this idea that by just helping prevent or not failing to prevent a certain number of infections, we might actually prevent a whole bunch of other ones, individuals who never even got the intervention in the first place. But that brings up a second point, and that's around, how much coverage do we need? How much do we need to scale up? And that comes out to really understanding a point that Malika made, which is around the heterogeneity, or what are the asterisks, not necessarily around sort of the context of breastfeeding, et cetera, but who is not at U. And, somebody mentioned around, what do we not understand about incidence? Well, we know that as long as, who's not getting PrEP? Well, those who are getting infected with HIV. So we have some understanding that there's enough heterogeneity that when we think about coverage, we need to understand the heterogeneity. And we need to understand heterogeneity in 3 aspects. The first is we need to understand, this is somewhat easier but not always done, we need to understand what's the heterogeneity and who's getting and accessing what prevention methods. What's the unmet need across different populations by age, by geography, by socio-demographic characteristics, by one's history, sex, gender, everything. Okay, so that's one. The second is we need to understand heterogeneity with respect to how these biomedical interventions actually work. PrEP works a little bit different in the vaginal mucosa. It works different in women than in men. So we need to understand what is the heterogeneity in these biomedical tools. The vaccine efficacy may not be the same in every single individual. The third piece of heterogeneity we need to understand is, what do we know about the sexual network? Sort of who are more connected and who are less connected. And essentially, the bulk of what we do, we're mathematical modelers, so we seem kind of boring, but we're really interested in who's having sex with whom, right? And so we really like working with people who are doing a lot of real sexual network stuff and trying to help us understand this, okay? So those are the 3 points. And then the next point, and it was brought up already, this idea that we need to sort of mix things up. We've got a bunch of tools, and the red is sort of a couple of the biomedical tools you heard about, and there's tons of other work that people are doing around behavioral interventions, structural interventions, etc. But this idea of mixing it up might seem like, yeah, we need to do that, but it actually has these really important epidemic advantages. Mixing it up allows for really important synergy. So things don't, in epidemics, the beauty of them and understanding them is that things don't actually add up 1 to 1, 1 plus 1 to 2 plus 3, etc. So the sum of the parts of an intervention, of a combination prevention package, will always be larger than each individual efficacy or effectiveness of an intervention. If we can get incidence down through one prevention modality, another prevention modality that we add, we may not actually need to do as much, especially if we understand the heterogeneities and who is getting access to those interventions. So mixing it up is actually quite complicated, and that's where sometimes the modeling helps, because how you mix things up could be very different in different communities and where the epidemic is at in different settings. Which sort of leads now to what Beth's going to talk about is around thinking about mixing it up in the contexts that support that.
I'm really just going to pick up on what Sharmista said, and I was actually also really glad that all my other panelists kind of brought up these issues around the social and structural determinants of health, because we know, when Abby was talking about looking at time to suppression or who's not getting suppressed, we know that a lot of that has to do with who has access to medication. If you don't have access to medication, if you can't afford your medication, you're not going to take your medication, or you're going to make it last longer and do other things like split your pills, share your pills, and you're going to be less likely to be suppressed. We know that, as Isaac was talking about, his awesome HIV prevention clinic at Toronto General Hospital is not typical, I would argue. I could be wrong on this, and hopefully it would be typical. But a lot of the work that I do now is on drug coverage, as I was getting at. And so one of the things that we're looking at is, even though in Ontario we have these public drug plans, we have Trillium, we have ODB, we have, within that context, we have people who are on disability who then get treatment. And so it was surprising in a cohort study that I'm working in to find that even for people who are linked to care, who are living with HIV, are connected to care, and are doing fairly well, there are still challenges with accessing medication. And so we thought, okay, we need to look at this in the broader context outside of a community who's linked to care. And we're finding that it's actually very common, even though we have Trillium and we have ODB and people are on disability or they're able to access it through private insurance, people fall through the gaps. It's not complicated. Even myself, I can speak to issues that I have with getting pharmaceuticals sometimes with my benefits. So I think in terms of the implementation piece around what Sharmista was just saying around mixing it all up is that we can't do everything in a silo. So even though we have all these great tools, we have PrEP, we have a vaccine that's coming, we have this U=U campaign, we have positive steps towards reduced criminalization for people living with HIV, they can't all exist on their own, because even if you just have one intervention at an individual level, you're not, unless you address the public policy, the social networks that people live in, the communities that they live in, if there's access to things like safe injection sites. So we know, for example, that we're experiencing a huge opioid crisis. It's probably been a long time coming. If we don't have access to places where people can go and inject their drugs in a safer environment and reduce the risk of overdose, if that doesn't exist in someone's community, then it's not going to work. We're still going to see new infections. The same goes with access to physicians. So as Isaac was talking, he has clearly, there's knowledgeable people about HIV and where to get PrEP, but those physicians don't live everywhere. People in rural areas completely struggle. Robert?
Sorry, I just wanted to encourage us, since we're really a few minutes over the hour, of opening the discussion and getting people into it.
Yeah, I really don't want to have a lot to say, but it's the idea that when we're implementing these biomedical preventions, that we have to consider the real world context. So even with the vaccine research that Taylor was talking about, even if you have a vaccine that's 70% effective in preventing HIV, are people going to take the vaccine? You have to consider all the real world. What's it going to cost? Is there going to be stigma associated with it? There's all these other players that go around that need to be considered when we're talking about these biomedical interventions. And I know that this evening, as Robert had pointed out right at the beginning, is that we can't solve all the problems in one night. And certainly this is not the main theme for tonight's event, but my job at the end was just to kind of remind us of that we can have all these great tools that work, but unless we consider all the other aspects that go on with people's lives, criminalization is a great piece. The disclosure laws, not everybody is criminalized in the same way. Certain communities are criminalized way more than others. And at the same time, we know that there's a lot of struggle in terms of people being able to disclose and get tested. So there's a lot of facts going on, but we are over time, so I will open it up to the audience.
Today, there's another new study that came out just a couple of days ago, which says that, you know, we have these banners 90, 90, 90, but we really might need to get 95. 95 linkage to care, retention in care, and return to care if we're going to show this kind of reduction.
Sorry, Robert, just to speak on that, we also have to remember that the 90, 90, 90, it's not really 90, 90, 90, right? It's 90% of 90% of 90%. And by the definition of 90, 90, 90, in the first place, we're already excluding 10% of the people.
Thanks. Really interesting and helpful conversation to hear. A couple of quick thoughts. I think this is really essential to see, you know, science and researchers and physicians who are so passionate and connected and doing such great work, and I think more and more working together and sharing sort of this last piece of like mixing it up and figuring out how, you know, how does what I've learned and discovered fit into a synergy when I link it to this other, you know, intervention and project, and then to tie that to part of what John said and what somebody said there about also just remembering, like, you know, how do people make decisions, right? So the piece around the lived experience is the other tension that we have to then translate, like a really well-coordinated and well-integrated sort of mix of interventions, and then have that translation into, like, what does that mean in the individual life and the tensions that we naturally deal with. Like, you can equals you for me as an HIV positive person. My choice around what that actually means for my psychological willingness to make a choice with the person that I'm having sex with will be completely different than the PHA sitting next to me, right? And there's that, so how it's interpreted in the lived experience is another layer that is kind of the next step that there's still some work there to kind of sink that piece into all of this stuff, but we're getting close, and it's exciting, and this has, you know, been very helpful, and I appreciate the work and the comments tonight.
Does anybody else would like to add something? Really, from any quarter, it'd be great. I'll just keep rambling or summing. But
I'll say something.
Go ahead.
I just wanted to say that, you know, with Trillium, for example, that some people, like when I tell people this, when I learned this, I had no idea, but Trillium was actually born from AIDS activism. That's right. So we have to remember the importance of the community and the power of the community to really be driving all these changes. And the rest of us are just kind of there to help provide some evidence and be allies, I guess.
I just wanted to add that I really appreciate the conversation around lived experience and actually understanding what some of these interventions mean for people in real life, because I think without that understanding, my bias is that I really like qualitative research and that's the kind of work that I do, but without that kind of knowledge, we miss some of those bits, right? Like, I'm not represented at this table. Does breastfeeding apply to me? I'm not represented at this table. What does this mean for people of color? Those kinds of conversations really come out when we're discussing lived experience, because otherwise we can get lost in the data sometimes. And similarly with PrEP, you know, the PrEP demonstration project that was done in Toronto, there's some really interesting data there about why people use PrEP and what PrEP means to them, right? It's not all just about, well, I want to bear back, and although some of it is, and that's fine too. People want to have good sex and what they consider good sex, and that's fine. But a lot of people talked about, I have been afraid to have sex until now, right? People talked about trauma. People talked about being empowered to take their sexual health into their own hands when they felt that their sexual health wasn't being considered by their partners. So there's all sorts of reasons why people might use PrEP or what might engage in any of these prevention technologies. And I think, Sharmista, you're talking about this idea of mixing it up. Understanding why people might use particular technologies or what they might mean for them can only help us understand how best to mix it up in particular contexts, I think.
So we are over the time, so that means, tremendous thank you to all of you for staying for such a great evening and for the kind of discussion we have. And, I'm convinced that what I started out saying at the beginning is true, that these are amazing people that we heard from. And to me, by the way, that's a good and a bad thing. I really meant what I said about Isaac, how fantastic that somebody can go to see him. But we really need Isaacs all over. It should be usual, it should be permeable. These people are special, and my goal is that someday they won't be. And again, and that's another compliment. I realize this is on recorded and everything I say is going to be held and used against me in the future, but I really appreciate everybody coming out tonight. It was great. And again, this was just a little spark of a beginning of a thing that we hope is going to have other kinds of forums to get to that real incidence reduction. So please thank the panel.